All right, we got 6 studies on the docket. Let's knock them out. Effects of positional traction integrated with mobilization with movement on cervical facet joint syndrome. So first, what is cervical facet joint syndrome? They say it's common, but it's not as common in the neck as it is in other parts of the body, just given the structure of the neck and other things that can cause pain in the posterior part of the neck. But what it really is if it's a facet syndrome where your spine Lincoln logs together, we have some sort of irritation in this joint structure. Typically, you'll have increased pain when you're looking up and when the joints are stressed in that direction. So for whatever rhyme or reason, they found patients that had this cervical facet joint syndrome, and we can then already presume, based upon, if it doesn't like this and things are crammed together, inflamed, etc., we can already probably guess that adding in positional traction with mobilization with movement, where we're literally going to be adding a little bit of gap and free flowing movement into those joints, they're probably going to wind up a bit better for better for wear. And that's exactly what they found. So they had 114 participants randomly allocated between the groups, ones that received care for the intervention versus ones that received standard therapy alone. And the results showed improvement. The conclusion basically says that integrating positional traction with mobilization with movement into conventional physiotherapy yields superior clinical outcomes for those patients. The combined approach effectively reduces pain and disability while improving cervical mobility and can be considered a valuable addition to rehabilitation programs. Just makes sense. This is one that shouldn't surprise us in any capacity. And I really just highlight it because, for those patients that are wondering, like, what are we doing? Something along those lines, if I think you got this. I don't really have much to say about it. It's just cool. It makes sense. And if we just have a little bit of education on what they're talking about, cervical facet joint syndrome, what might make that better? Well, giving a little temporary distraction in the neck and getting it to move in pain-free or relatively pain-free ranges of motion may have benefit. Who knew? But let's unsarcastically move on to the next study. Comparison of intrinsic foot muscle function in patients with different lower extremity conditions. Basically, they tried to cheekily say that the intrinsic foot muscles, so the smaller muscles, the stabilizing muscles of your foot, act as the core of the foot, much like your core muscles do for your torso. What we really need to take from the study first is that the conditions that they wanted to evaluate the intrinsic foot musculature with were chronic ankle instability patients, patellofemoral pain patients, first metatarsal phalangeal joint arthrodesis in patients with diabetes patients. And what they did with this study is they took an ultrasound and they measured the cross-sectional area of these patients and compared them to healthy norms to see if there was a difference. And unsurprisingly, there was. What they found was, let's see, with a bunch of research jargon, the differences in cross-sectional area of one of the foot musculature muscles, the abductor hallucis, were found between all pathology groups and healthy controls. Cross-sectional area of another one, the flexor digitorum brevis muscle, showed significant difference in all groups except except for two. Significant differences were found between groups for both muscles. Basically, they found differences. So their conclusion was, here it is. Significant changes in muscle size and quality were observed, suggesting that clinicians should assess and target the intrinsic foot musculature rehabilitation to improve foot and ankle function in those populations. Again, I kind of have a make sense situation. I mean, if you have chronic ankle instability, ankles, you should be assessing ankles and feet, which means you should be getting a rough estimation of how well these patients are utilizing their foot and their foot musculature. Same thing with patellofemoral pain syndrome, knee pain, or a variety of knee pain. I'm looking at the patient's lower extremity function. If you're doing an adequate job in assessing the whole area rather than being really myopic, you only have knee pain, I'm only going to touch the kneecap. You're not going to see a whole lot from that. You have ankle instability. I'm going to look at just the ankle for some strange reason because you don't understand anatomy and how the foot functions. You really need to be looking at these things from a whole person perspective, a patient perspective, a functional perspective. And while there is diminishing returns looking at really far away points in the body and trying to connect them, like if you have pain in your pinky and I tell you to take off your shoes, I need to see your feet, you can look at me funny. But if you have foot pain, I'm going to look at the foot. If you have knee pain, I'm going to look at the knee, the foot, and probably the hip. If you have hip pain, I'm going to look at the whole hip and lower extremity and probably the low back. If you have low back pain, I'm looking at the whole spine and the hips at the very least. If you have neck pain, I'm looking at the back and the shoulders because your body is interconnected. There is diminishing returns from trying to connect certain parts of your body to the other, like I made an example of before, but others do make more sense. Like when you consider the size of the traps, where they connect from and to, it makes sense that I would have to evaluate the whole area that they cover if you have an issue with the trap muscle itself or a region that they are near. Same thing with the spine. Like there is multi-layered interconnections between your spine where it may be relevant to look at something a little bit farther away from your actual symptom source, the pain source, because that may be something that, even if it's not a cause, is a factor in your current condition. Because it's not that you ever, let's take range of motion, for example. I have a I have a tough time touching my toes. Oh, everybody, that's tight hamstrings. Is it tight hamstrings? Is it the low back? Is it the mid back? Like what's really going on here? Is it the feet? You don't know. You need to assess. Um, I bring that up because people will think, oh, if I can't touch my toes, it's either hamstrings or it's one specific part of your back. Your back's ability to move is additive and cumulative. You only have typically minor degrees of motion between any two vertebra or spine pieces, essentially, but it's the added effect when you add 2, 3, 4, 5, 6 pieces of spine. If they have just a couple of degrees of movement, that adds up to allow you to do the full movement. So that's why I just bring it up. So if you have a tight, stiff mid back, or we measure your range of motion and it's not where we want it, we have to look at the whole spine because it interconnects and acts together. So, summary, parts are interconnected. This one's talking about the intrinsic foot for these conditions. You should assess it from a whole person perspective, which means you should have already been looking at the foot muscular in the first place. If you have these conditions, you can look at interconnected parts of your body that will probably have a factor in your condition, and there is diminishing returns after a certain point. I could get into other studies like the XPO study, extremity pain of spinal origin, to kind of highlight my point further, but we've got 4 more studies to get through, and I'd rather get through these studies today. So the next one, BFR training compared to conventional training in people with knee pain, a systematic review with meta-analysis. This one's controversial, so I'm going to go through it, but then I'm going to give my 2 cents. And the rest of the studies hopefully will go faster because I might spend a little bit of time on this one. Highlights, we need to put some asterisks on this one. BFR training can significantly reduce short-term knee pain. Asterisks. No significant effects on knee function or strength were identified. Okay. Randomized controlled trials in this field are small and have high risk of bias. Highlight that one. Caution is needed in offering BFR restriction to people with knee pain. Yeah, I agree. So, what do they do? Well, they search some databases all the way up through 2023 looking for RCTs, randomized controlled trials, involving participants with knee conditions and using BFR therapy in at least one intervention arm. They found 15 RCTs involving a little over 400 participants that were eligible for study, investigating people with post-anterior cruciate ligament reconstruction, cartilage surgery, knee osteoarthritis, and patellofemoral pain. And what did they find in the results? Very low certainty evidence that adding that BFR training to resistance training is superior to resistance training for pain outcomes. Very low certainty evidence that adding BFR training to resistance training is equivalent to resistance training for function and strength outcomes. So the conclusion was BFR offers a significant effect on short-term pain that is of questionable clinical relevance because it is a very low certainty evidence, and no significant effects on function or quadricep strength. Future quality RCTs are required to appropriately explore clinical efficacy, and clinicians should exercise caution in offering BFR to people with knee conditions. And I agree. Do we use BFR? Yes, we do. Do we use it on everybody? Oh, no, because it is an intense therapy if you do it right, which is why I kind of laugh as far as the it improves knee pain thing. If you do it right, maybe the immediate knee pain, but where that cuff is in your whole lower leg is going to feel intense. So let's talk about it. Let's talk about it. What these RCTs are measuring aren't that much of a surprise to me as far as the immediate low level conclusions. BFR will not beat out traditional progressive overload resistance training. It can't. Okay. If we think of if we think of exercise as a stress equation, where I'm going to put the body through a controlled level of stress so it adapts in ways that I want it to. There are tons of parameters I can play with. I can play with how long you're doing the activity, how intense or fast you're doing that activity, how much weight we're using with that activity, how much rest you're getting within the activity. There's lots of variables that I can use in that equation to try and get the appropriate amount of stress through your system for it to adapt. BFR cannot, in my current understanding and opinion, beat resistance training through any study that I've ever seen, through tiered progressive overload. Because progressive overload essentially is, it's almost like a law of nature. It is just what your body does as it responds to stress. So then what is the clinical value of BFR as it stands? Well, not just including this study, but other studies that I've come across, BFR is just changing one of the variables of the equation. When is it most typically used? It is in pathologies, typically post-surgical, where that tissue cannot be utilized for very long with a lot of weight. And it's essentially just very, very damaged tissue because it went through an extreme amount of stress. So how do you prevent it from atrophying? Well, they will use TENS units to just dummy, I call it dummy stimulate the muscle where it just works. But you can also utilize BFR because what it does is BFR acts as a pseudo tourniquet, slowing blood flow through a limb, and that causes a metabolic stress in the limb that, as far as a theory standpoint comes in, chemically stresses the limb enough to think it's going through more stress than it actually is. So you don't have to load it as hard or as long to get an adaptive stress response in the tissue distal from or further away from the actual cuff. Put another way, let's say I tore a bicep or something, or I damaged this where I needed significant surgery in my arm elbow region. Let's say I can normally, for easy math, we'll say I can curl 50 pounds. I can do a lot more, but we'll just, for modesty's sake, I can curl 50 pounds with my non-injured arm. I'd be lucky if I could curl 15 pounds with my left because it is damaged. My body won't let me lift more because the tissue cannot handle it. Well, you can slap a BFR cuff on, stress the limb, the arm here, put a 10-pounder in, and you can start repping things out, and the body should overcorrect for the amount of weight you used. That's the theory behind BFR. So we can use it for tissue that cannot handle a normal level of load to try and get it to adapt while we wait to essentially start switching it over from non-BFR, progressive overload, classical rehab and training. So it is at a certain time standpoint for certain pathologies, potentially useful. The other time that I can see its utilization is actually in its short-term pain response effects that this one kind of highlighted. So one that comes into mind in particular is a patient that I had with a knee meniscus tear. And when you're dealing with a non-traumatic knee meniscus tear that is physically, even though it's a meniscus tear, functionally fine, your body's putting on the brakes because you now consciously know there's a tear there. There's enough pain in the area where you went and got an MRI and saw that there happened to be a tear. So now you're fear avoiding certain positions because you're worried about damaging the tissue further, even though in this person's case, they wouldn't. So utilizing BFR, we change the person's, what's the word I want to look for? We changed her perception of how the leg felt going through certain motions that would have been sensitive. So like squats and side squats or side lunges would have been very irritating. And they were, especially just body weight and pure body weight. But hooking up the BFR gave her a new stimulus to focus on while we rehabbed her through getting the body to accept certain positions again. So was it the theorized BFR benefit where it accelerates, and over exaggerates the stress response? In her case, that wasn't what I was going for. If it had a benefit and if it was, clinically effective in her case, sweet, it's the cherry on top, but not the reason that I used it in her case. In her case, it was to stress the limb in a way that overloaded her traditional pain response to allow her to do these different positional movements so that she became comfortable again, that when we took it off, the brain's just like, oh yeah, that's the leg's not under any duress by comparison now. Let's do these movements. So there's a couple of different ways that we can use this that may not be quote unquote fully researched backed yet, or researched in a way that asks the right question that it can be utilized in. So is BFR useless? No. Is it the panacea where some clinics only use BFR and that's all you should be doing? Also, no. It is like anything else, just another tool that you can apply for the right patient at the right time that may be effective in their care. So no, not all. In fact, a small contingent of my patients get BFR, and it is when we need to check off one of those boxes. Either the tissue cannot do a traditional progressive overload as much or as fast as the patient and I may want, so we can utilize it to see if we can speed up's the wrong word, but perform these movements in ways that we're both happier for, and we'll have more, again, buy-in's also the wrong word, more, I know the word is on the tip of my tongue and it's going to bug me that I can't think of it because it's a simple word. Patient compliance. If the patient is going to be more compliant with exercise because they feel that the additional stress that the arm is going through and the potential few days to a few weeks of sped up benefit is of benefit to them, we'll use it. Or if it's a way that we can get the person's body to work around a traditionally painful movement because we're stressing and overloading the limb in a way that it's not used to, we will also use it. So that's my 2 cents on BFR. There's, studies coming out that are pro, anti. Studies are all over the place on this one. So I agree with the highlights in the sense that caution is needed in offering BFR restriction to people with generic knee pain. Like, you really have to pick the right patient for this therapy. And you also got to pick the right conditions that it would be warranted for. Randomized controlled trials are indeed small and have a high risk of bias, again, either for the therapy or against the therapy. No significant effects on knee function or strength were identified. Again, because you can't beat progressive overload, that is the tried and true method. And I kind of giggle a little bit when I see the first highlights. So that's why we did the asterisks. That's why we talked through it. I really only have one more study that I kind of talked through a bit, and the other two are just, hey, here's a point, and let's end this thing. Dry cupping therapy combined with conventional therapy does not provide additional benefit over conventional therapy alone in patients with non-specific chronic low back pain, a randomized trial. We use cupping quite a bit in the office. We do use dry cupping, so dry versus wet. Wet is something that can be utilized in more Eastern medicine, where you actually make a controlled incision in the body, use the vacuum suction of the cup to actually draw blood out of the area. We don't do that. We don't want to do that. So dry cupping is no incision is made. And traditionally, in this sense, the therapy is just a passive cup laid on an area for a period of time that ranges from 5 to 30 minutes. That is a version of cupping. It is not the one that I typically do in the office, which is also why I wanted to talk about this when I saw it. So they had 36 patients with chronic nonspecific low back pain, randomly divided into two groups, control and intervention group. Basically, the intervention group got everything the control group did, plus cupping. What was everything else? It was core stabilization exercises, spinal manipulation, and education for 4 weeks. The primary outcome was a visual analog scale for pain intensity, and they had other questionnaires that they used to see if anything else was going on. Those were some traditional ones as far as Western medicine was concerned, but they also utilized some Eastern medicine questionnaires like the Shenshu, and I'm not even going to try and pronounce these other two because you might come after me for it. And at 4 weeks, they really found nothing clinically beneficial between the two groups, whether it was traditional intervention or cupping on top of it, which, no surprise, for multiple reasons. One, you picked a very, very wide condition. There are so many things that could be causing chronic nonspecific low back pain. It is ridiculous. So first, you have a condition that, if you're throwing cupping at it, if you throw any intervention, any singular intervention into such a dynamic condition, best of luck to you. Like, if we have singular interventional studies, I am very skeptical on either result from them, either good or bad, when it comes to chronic nonspecific low back pain, because I'm highly suspicious of any panacea with such a diverse condition. And I'm also skeptical of any pure negative throwing the baby out with the bathwater study, kind of like this one, because of how dynamic the condition is, as well as typically the setups for these actual studies. So if we're just doing passive cupping to a group that is already receiving part of the standard of care for chronic nonspecific low back pain, that is some sort of rehab. It just happened to be core stabilization because it's popular. Spinal manipulative therapy, which is actually part of one of the first-line interventional therapies you can utilize for chronic nonspecific low back pain, and education, that already has great clinical efficacy for this condition. So adding something like cupping on top of it, you're not going to see the benefit. Not really. Not unless you subcategorize potential factors or potential subcategories within chronic low back pain that may be more beneficial from receiving the cupping, such as, superficial nerve irritation usually responds well to cupping therapy. Certain myofascial or muscular pain syndromes or skin pain syndromes can be beneficial from therapy. If the pain has a more ischemic nature or lack of oxygen and blood flow to a certain region, cupping can be of benefit. So if you just randomly assign, without trying to subcategorize, at least a direction or a flavor of low back pain you're dealing with, no surprise that when stacked up against what is arguably maybe not gold standard, but a pretty good standard of care for this condition, it doesn't perform any better, I'm not surprised. So this one, I'm not going to say it's a waste. It gives us a talking point and lets me kind of add a little nuance to the conversation, but I'm not going to throw out or stop doing cupping with this. Kind of like with the BFR, the cupping doesn't have to necessarily have any immediate benefit to the condition. Sometimes it just changes the person's perception of the area enough to get them to do movements that we want them to do. So was cupping actually curing their low back pain? No. It was just a tactile sensory trick that we got the patient to utilize their bodies in ways that they're not used to in a safe manner. Now, sometimes if we find somebody has cluneal nerve irritation or Main syndrome or other conditions like that, where you have a peripheral nerve irritation or entrapment, having a focal decompression force can be utilized and sometimes is of great benefit for patients in acute distress. So you really just, it comes down to the diagnosis. It comes down to knowing what's going on and knowing that it is such a dynamic condition that I could start a whole hours long podcast, live feed, whatever it is, on just that aspect of chronic nonspecific low back pain. Because you have mechanical factors, psychological factors, environmental factors, chemical factors. You have so many factors that you have to juggle that it makes studying it a bugger, treating it just as much an art as it is science. And you really just have to understand you're dealing with people at the end of the day. And that's where a lot of people get more benefit than having any singular perfect intervention. Is like, you could have the best therapist in the world, worst communicator, you have just basically the same odds of getting better as anybody else who's a great communicator, because you're dealing with a person. And if the person has facets of their pain that are non mechanical that the therapist is hitting, but the person's talking to you, the other therapist is talking to you, they're both just as likely to get great results. But I'd lean more towards the communicator, because then you can also add education and coach people through rehab and tell them why it's important. And that'll get you probably better benefit than just somebody who's really good with their hands. Now, you could also find a clinic like wink, wink, nudge, nudge, mine, where you can put our skills to the test to see how we stack against other people you're used to for any of those categories, hands-on and communicating. So wink, wink, nudge, nudge. Last two. Investigation of the effect of different intensity stabilization exercises on core muscle stiffness and pain in chronic low back pain, a single-blind randomized controlled trial. Put simply, reading through all of this, it is they had people do home exercise program, come in to see a therapist twice a week for core stabilization, supervised core stabilization exercises, and 4 times a week for core stabilization exercises. And they found that, shockingly, the more that you did it, the better you seemed to do when you were supervised by the therapist. Right here, supervised when it was performed 4 days a week is statistically more effective in increasing muscle stiffness and reducing disability than exercise performed 2 days a week. So really scratch out the stabilization exercises and just put in the fact that if you dose exercise rehab appropriately, you get better results. So if you have the person working out 1, 2, or 3 days a week, rehabbing 1, 2, or 3 days a week, they're probably not going to get the results they want as fast as they want, compared to the person putting in more effort that is dosed appropriately, doing things more consistently. That's all this was. So we can do all of the studies, the group ones, the analyses, all of this. We can really distill it down to, we should have asked the question of, if we give the person a more consistent prescription at a good dose, are they going to get better over somebody who we sporadically give this intervention to? Yes, especially in the world of movement and exercise. Can you overdo it? Yes. Can you underdo it? Yes. That's why you have purgatory and you have roller coaster. Purgatory, I'm not getting any better because I'm not dosed appropriately, or I'm constantly re-hurting myself because you're not dosed appropriately. You're doing too much with too little recovery. You got to walk the line. You got to find that balance. And the people that were dosed right here, or better, or it was 4 times a week with the person watching them, you got better. It's no surprise. I don't need to say anything else. Last study. Let's finish this. The role of spinal and hip mobility and disability among patients with chronic low back pain. Skipping to the conclusion. Spinal and hip mobility impairments are independently associated with disability in individuals with chronic low back pain. Notably, hip mobility was equally relevant as spinal mobility, underscoring the need for comprehensive mobility assessments in clinical practice. Yeah, go back to the study that I talked about with intrinsic foot muscles. You need to look at the whole region, the whole area, and you need to see what the person needs to utilize to do the movements that they can no longer do as well and treat them appropriately. So if you have low back pain, but the person is only touching your low back, the provider is not doing a good enough job to give you a whole picture on what is actually going on. So if you have low back pain, I'm looking at your low back, your hips, everything else to get a full clinical picture of what needs to be done, because you're not just a back, you're a person. You got hips too. All right. So I don't even have a rant, or correction. I do have a rant, but I don't want to use it because I think that is succinct enough for this study. Thank you for sticking with me for this long, and until next week.